Good evening, doctors. This is Dr. Kiran from Shield Medical Affairs, and I would like to give a warm welcome to all of you for being kind enough to log in to this very interesting webinar. The topic of the day is the mysteries of ICSI and male infertility unraveled, and this is a very complex subject, and to make us understand. With a lot of practical as well as clinical experience, we have with us none other than Dr. Jatin Shah. Sir needs no introduction. However, I will just say a few words about Sir. Sir is a ART specialist. Currently, Sir is the director of the prestigious Mumbai Fertility Center from Mumbai. And Sir has got quite a lot of academic achievements. Sir co-authored quite a lot of journals and articles. To name a few, one is the Photographic Atlas of Gynecology and Obstetric Operative Techniques. Sir was awarded several gold medals during his academic tenure. Sir was associated with the prestigious KM Hospital and Research, and especially in the introduction, in reproduction during the inception and birth of India's first test tube baby. And Sir was trained. Sir had trained in IVF and ICSI with none other than Professor Arif Bongso from Singapore. Sir has been instrumental in being a pioneer in establishing IVF and ICSI centers in several cities across the country, from almost past 20 years. Just to name a few, Cochin Vijaya Fertility, Sir did the first ICSI and IVF pregnancies of Kerala, in Pune, in Agra, especially the first ICSI and TISA ICSI pregnancies of UP State, Madurai, the Sumati IVF Center, Erode. So Sir has successfully had almost more than 500 successful pregnancies at each of the centers, and Sir is very popular for his abilities to deliver consistently high success rate and troubleshoot various clinics and laboratory problems associated with IVF practice. In terms of professional achievements, just to name a few, Sir successfully established pregnancies in more than 15,000 infertile couples way back since 1994. In 1995, Sir won the first prize in the best paper presentation category for the topic IVF in tubal factor infertility. Sir was a founder member of ASPIRE, which is the Asia Pacific Initiative for Reproductive Endocrinology, having numerous presentations and publications nationally and internationally. And currently, Sir performs almost 2,000 cycles of IVF and ICSI per year, with an average of 80 to 100 IVF pregnancies a year. In terms of publications, just to name a few recent publications of Sir, Sir conducted the largest study on the use of GCSF in patients with repeated implantation failure and thin endometrium. This was published in the year 2014 in the International Journal of Infertility and Fetal Medicine. Sir published the association between progesterone elevation on the day of human chorionic gonadotropin trigger and pregnancy outcomes in the Frontiers of Endocrinology in 2017. Sir published as early as 2018. Sir published the article on preterm birth among pregnancies conceived by ART in Mumbai. It is an original research article paper, and it was published in the International Journal of Reproduction, Contraception and Gynecology in April 2018. So it's such a great and immense experience. I'm sure that Sir will throw a lot of light on this very complex subject. Welcome to you, Sir. Over to you, Sir.
Thank you, Kiran, so much. A big thank you to Shield Healthcare and of course Shield Medical Services for providing this platform once again for me. Today I've selected a bit of a complex topic because I'm so used to talking of female infertility all the time and ovarian stimulation. So I thought it would be a nice change for the audience and for me also to talk about something else, and that's why I thought an area which is often neglected because we are all gynecologists, and it would be nice to give some more details about male infertility where we are today, and some pros and cons of how ICSI should be done and how it shouldn't be done. So I'll just begin by sharing my screen. Okay, so today we are going to talk about the mysteries of ICSI and male infertility unraveled. We all know that male infertility contributes quite a lot to infertility on the whole. And if you see this, it is responsible for infertility in almost 50% of the total cases of infertility. So it's a huge problem. And as gynecologists, because most IVF clinics are run by gynecologists, we often tend to neglect the man and don't give it the due attention that it requires. What are the key causes for this rise in male infertility? We know, of course, late marriage we thought always only affects the female partner, but we also know that with advancing paternal age too, there is a problem of male infertility which increases. Decline in semen quality, which we've all been discussing for the past 2 decades. A lot of environmental causes such as pesticides, occupational exposures, pollutants, and so on. Lifestyle disease is probably the number one cause right now in terms of obesity, stress, alcohol, smoking, unhealthy diet, too much of traveling, and so on. Diabetes, especially in the Indian perspective, is very common and a common cause of male infertility. And of course, you have erectile dysfunction. Do we have evidence that sperm counts are indeed declining? Yes, we have. And you can see these two graphs here, and you can see clearly that over the period of 1973 to 2011, we have seen a 50 to 60% decline of sperm counts among men, with no evidence of any leveling off in recent years. So the decline continues to occur over with every passing year. And this is indeed a cause of concern. We all know that initially sperm counts more than 20 million were considered normal. Now 15 million is considered normal. Initially it was 60 million, which was considered normal. So even the normals by the WHO are being brought down with this decline in sperm counts over the years. Is it the other way too, that low sperm count also indicates that there may be some male disease in the form of his general health not being perfect? Like low sperm counts are often indicative of the metabolic syndrome, as shown by a higher BMI and obesity, elevated blood pressure, higher risk of diabetes, heart disease, and stroke. Also, low sperm counts often indicate low testosterone, which is associated reduced mass and bone density, and could be a precursor to osteoporosis. Also, an impaired quality of life and a shorter lifespan. So when men with low sperm counts, 20% more likely to have more body fat, higher blood pressure, and more bad cholesterol. So this is a very important study which was recently published. Causes, all of you are familiar. Of course, this is a post-graduation textbook stuff. Pre-testicular causes in the form of hypothalamo-pituitary disease. Testicular causes may be genetic in the form of Klinefelter or some other genetic defects, or maybe non-genetic in the form of the presence of a varicocele or Sertoli cell-only syndrome or effects of chemotherapy or radiotherapy. And of course, you have post-testicular causes, which are also very common, like a blockage of the ductal system, congenital bilateral absence of the vase, acquired blockage, anti-sperm antibodies, ejaculate duct obstruction, and so on. Of course, it's not in my domain because it would be in the domain of the andrologist to really take you through how to evaluate and how to do all the testing and all that. But what a gynec needs to be aware that, of course, the medically treatable conditions are such as endocrinopathies, ejaculatory dysfunction, infection, erectile dysfunction, and so on. Surgically correctable conditions like the varicocele, testicular torsion, cancer, cryptorchidism, and of course, reversible causes such as lifestyle, sometimes with radiotherapy, chemotherapy, medication, and sometimes the drugs which are used. In the evaluation, of course, we know that history, physical examination would be done by the andrologist. Investigations, conventional semen analysis, of course, is the most important. At least 2 semen analysis should be done before you label a man as a case of oligoasthenoteratozoospermia. More recently, we have also started checking sperm DNA fragmentation, or the SDF or the DFI, as we call it, which is especially useful in patients of unexplained infertility. Now, this is one of the most neglected areas because a lot of unexplained infertilities, we later on find out when we do IVF that 70 to 80% of them have fertilization failure as a cause of their infertility. So it's useful to assess the sperm DNA fragmentation here, because if it is more than 20-25%, it is better to do ICSI, as I will show you subsequently. And of course, more recently, a lot of importance is also being given to the role of oxidative stress, reactive oxygen species, ROS, and so on. And several tests have now been advocated for assessing these two in the infertile man. Blood tests, of course, you would have hormone estimations. Usually just testosterone and FSH suffices. You could add LH, prolactin, and estradiol if testosterone is low. Karyotype and Y chromosome microdeletion analysis could be done for patients with azoospermia or severe oligozoospermia, and of course, various mutations for patients of congenital bilateral absence of the vas. Radiological studies, of course, when indicated as per the andrologist's advice. scrotal ultrasound, rectal ultrasound, MRI pituitary, and so on, as and when indicated as per the patient. So if you look at the conventional semen analysis, we used to look at concentration, motility, morphology. All of you are familiar with that. We have more advanced tests now for assessing sperm DNA fragmentation, such as the tunnel, the SCSA, SCD, and COMET, reactive oxygen species with the myoxis, acrosome reaction, sperm zona pellucida binding, and mitochondrial function. So these were the tests which were done in the olden days. These are the tests which are presently being done, and the future obviously lies with genomics, proteomics, and metabolics. Very important point, and one new addition to my lecture today is which has been neglected, and that is the global incidence and the role of male oxidative stress infertility, or MOSI as it is now known. If you look at these statistics, if we talk of say 186 million infertile couples, almost 30% would have a combined male and female factor, 20% would have an exclusive male factor, which makes male factor responsible for 50% of infertility, that is 93 million couples. Of these, 50% would have a known cause of infertility, 50% we would call idiopathic, and in this idiopathic group, 80% would have oxidative stress as the cause of infertility. So male oxidative stress infertility would be responsible for almost 37 million couples out of the 186 million total infertile couples in the world. So this is a really huge statistic and a grossly neglected area of medical treatment for the male partner. We know that reactive oxygen species is of course physiological, and it has an important role to play in sperm maturation, motility, morphology, acrosome reaction, fertilization process, and so on. But if it is excessive, if you have unregulated ROS production, which could be due to exogenous reasons like radiation, toxins, smoking, and alcohol, or could be endogenous like infections with leukocytes, too many immature sperms giving excessive residual cytoplasm, or the presence of a varicocele giving testicular hyperthermia and hypoxia. And all these in turn would result in oxidative stress to the sperm in the form of lipid peroxidation, damage to the DNA and very high DNA fragmentation, and apoptosis of the sperm factors. So this is how ROS, excessive ROS, will affect and give you such a high incidence of MOSI. Of course, there are tests now available to assess the level of oxidative stress. And usually the treatment would be, of course, to remove the stress factor, like for example, smoking, drinking, occupational hazards, etc. If there is infection, you treat with appropriate antibiotics. Varicocelectomy in select cases would also help to reduce oxidative stress. But the main treatment for us as gynecologists would be the administration of antioxidants. Now, antioxidants we have all been using for improving semen parameters, reducing the oxidative stress, reducing sperm DNA fragmentation, and improving pregnancy and live birth rates. Various antioxidants act at various levels, like L-carnitine is important for sperm motility, L-arginine for vitality, vitamin C and E for sperm counts and concentration, and so on. And we have a huge number of formulations in the market to select from. What is very important is that you must remember that what is the role of each of these antioxidants. So when you assess and select a particular product for a given patient, try and correlate with what the problem is. So if he has a more of a sperm oligozoospermia, then what would you prefer? If there's more of a morphology issue, what would you prefer, and so on. Personally, I prefer a combination of 100 milligrams ubiquinol and 40 milligrams resveratrol, besides, of course, vitamin C, vitamin E, and so on. And we now have this huge study published in 2020. And this is one of the largest clinical trials on actual use of antioxidants and the effect on sperm function in especially patients with idiopathic or unexplained male infertility. So they had 148 patients, of which 108 patients, almost 91%, were confirmed cases of oxidative stress infertility. So almost all of them, you could say, did have some form of oxidative stress. And with the administration of a combination of antioxidants for 3 months, you can see there is a significant increase in sperm concentration. This is post 3 months of treatment is the green. Yellow is before treatment. You can see motility improvement, progressive motility improvement almost by 143% in most of these patients. Also, you can see significant increase in morphology, 86% increase in normal sperm morphology, significant decrease in oxidative stress, and a significant decrease in sperm DNA fragmentation. So we now have evidence with this perfect huge clinical trial that antioxidants are here to benefit a lot of these patients with oxidative stress as the cause of infertility. So we know this study finally tells us that yes, it is no longer just empirical to give antioxidants, and we have evidence. It improves sperm parameters in unexplained infertility and idiopathic infertility men. And of course, you have to give it for a minimum of 3 months. You also have to take into consideration whether you can combine water soluble like vitamin C with oil soluble like vitamin E and so on. So be very careful, go a little bit more into the pharmacodynamics before you select a particular brand or formulation for male infertility. Coming to the main part, that finally, of course, once the andrologist is done, the medical treatment is done, the varicocele if required is done, you've given your antioxidants for 3 months, you've done your trial of conception, natural conception, you've probably done 2 or 3 IUIs also. Finally, it is ICSI which helped to revolutionize completely all kinds of male infertility. So even patients with severe male factor infertility, with even very poor sperm counts or zero sperm counts, who would otherwise never have greeted their own biological offspring, today are able to have their own genetic children. Of course, it's now more than 25 years since the birth of the first IVF baby, ICSI baby, and we still have a lot of debate about where the application should be. Should we be doing ICSI for all male factor? Should we be doing ICSI for all patients of infertility? And whether it is safe enough to do so, and so on and so forth. So let's review all the available evidence to us. And am I saying as a take-home message that all male factor needs ICSI? No, it doesn't. And as I mentioned earlier, we have these recommendations from 2012 from Tourne, who very clearly said that, of course, IUI should be considered as a first-line treatment if your good gradient sperm wash on a good gradient gives you more than 1 million rapid progressively motile sperm, then you can do 3 to 6 cycles of IUI if you have a young, normal female partner. So this is very important to remember, that once you've done all your medical surgical treatments, a definite trial of IUI if you have a reasonable recovery after a good sperm wash. But if you have a very poor recovery, or if the sperms are not normal morphologically or motility wise, even after processing and all your antioxidants and medical treatment, then of course ICSI would be a first choice for moderate to severe male factor infertility. For any great breakthrough or technique in science, a little bit of history is always important and fascinating, because we know scientists, when we had IVF 42 years ago, we still couldn't treat moderate to severe male factor infertility because it often ended up with fertilization failure. So all the endeavors were to try and put the sperm closer and closer to the oocyte. And we started with zona drilling, just making holes in the zona, hoping that the sperm would go in, zona softening, partial zona dissection, finally SUSI, that is subzonal injection of a single sperm, trying to avoid penetrating the cytoplasm because scientists thought that would damage the oocyte and cause oocyte degeneration. And it was a sheer laboratory accident. One day while Palermo was trying to do a SUSI, he inadvertently punctured the ulema of the cytoplasm, injected the sperm into the center of the oocyte. He thought the egg is lost, and the next day he found a good 2-pronuclear zygote. After 48 hours, he had a lovely embryo. He transferred it to give us the world's first ICSI baby. So it was a laboratory accident which actually gave us the first ICSI baby in the world. Of course, to date, we now have more than 2 million babies worldwide born with this fascinating technique of ICSI. And the beauty of ICSI is that it is able to completely bypass a lot of problems like zona pellucida problems, irregularities, presence of anti-sperm antibodies, any dysfunction of the sperm acrosome, or the presence of sperm kinetic defects. So you practically bypass all the things that we were taught were important for fertilization of the human oocyte when you do an ICSI and help the couple to have their own biological child. Not only sperm with very poor count, very poor motility or bad morphology, but we now apply ICSI even for azoospermics, as long as you can microsurgically retrieve sperm from the epididymis or the testicles of these patients. So this has now confirmed that ICSI is not affected even by the maturity of the male gamete. So even sperm retrieved directly from the testicle can give you a good biological live birth. And that has resulted in us pushing the boundaries to application of ICSI to the most extreme aspects of male infertility, such as cryptozoospermia, virtual azoospermia, or even absolute azoospermia. Is ICSI for male factor really so successful? We hear IVF clinics telling us, oh, it's the same. You give me a blocked tube, you give me endometriosis, you give me male factor, all of them will give the same result with ICSI. And this was a paper which was done in 2017 to actually study whether this is true. And they compared the outcomes in male factor infertility with a group undergoing ICSI for tubal factor infertility. And they proved the point that yes, compared to tubal factor, male factor gives you the same fertilization rates as tubal factor and also similar pregnancy rates as tubal factor. So ICSI for severe male factor infertility, extremely successful, and the results are on par with IVF being done for tubal factor or other indications for infertility. What about unexplained infertility? Now, here again, there was a paper in 2018 which compared the outcome of ICSI for male factor with unexplained infertility. And you can see male factor actually does better. Mild male factor, mild to moderate, actually has a statistically significant higher live birth rate than unexplained infertility. And many of you would wonder why this is so, because unexplained infertility, apparently you have a man with a normal semen count, normal sperm motility, then why should the live birth rate lower? And this is where sperm DNA fragmentation comes into play, that a lot of these patients of unexplained infertility, in fact, have infertility because they have a higher incidence of DNA fragmentation in the sperm. So ultimately, the live birth rates are a little lower than actual documented male factor infertility. And even if you compare with not severe male infertility with female combined, severe male infertility alone, severe male and severe female or female, the live birth rates are pretty much on par for all these categories. So quality of specimen probably does not affect ICSI outcomes grossly as far as ICSI is concerned for male factor infertility. What about the source of the sperm? Most of you would imagine that obviously sperm which is in the semen or ejaculated sperm would always be the best and give you the highest success rate as compared to sperm retrieved from the epididymis in obstructive azoospermia or from the testicles in non-obstructive azoospermia. But you would be surprised that with epididymal sperm, you in fact get the highest fertilization rate and you also get the highest clinical pregnancy rate per cycle, because these are just cases of obstructive azoospermia. The spermatogenesis and the testicular function is absolutely normal. So sperm DNA is excellent. They don't have too much of DNA fragmentation, which is why you get a very good fertilization rate and pregnancy rate compared to ejaculated sperm. And the same second is testicular sperm, which also gives a little higher pregnancy rate than what you get with ejaculated sperm. Again, because of the same reason that the ejaculated sperm are cases of male factor with very poor sperm counts, poor sperm motility, bad sperm morphology, and which is why the pregnancy rate is not as high as with cases of obstructive and non-obstructive azoospermia in some categories of patients. So this is a really surprising and very interesting study. A lot of you would also feel, because all IVF clinics tell you, oh, you can just freeze epididymal sperm, you can freeze testicular sperm, you can do repeated cycles from the same PISA or TISA. You don't have to keep repeating that procedure thanks to sperm freezing, which is so successful. But is it really the same? And we now have evidence that this probably may not be the same. So if you see here, epididymal sperm, fresh versus frozen, testicular sperm, fresh versus frozen, frozen pregnancy rates always lower than fresh pregnancy rates. Now, this is a very important finding here because it implies that you might have to repeat fresh PISA and TISA and not rely on frozen leftover samples from the first cycle. This may not be the ideal thing to do for all patients. Of course, there were a lot of other studies by Haberman, Hollander, Schachter, which said that fresh and frozen are the same results. But this study, which was recently published, shows this. And this is one more study from 2019, again showing comparing fresh versus thawed PISA sperm, fresh versus thawed TISA sperm. And again, you can see that the live birth rates are lower with frozen samples. So this is probably the reason that they give, is that when you do a lot of teasing of testicular tissue to find the sperm, that teasing and the tissue shearing and shredding which occurs may affect sperm quality because of the release of ROS. So a lot of ROS is released when you do the initial teasing, when you've done a fresh PISA or a TISA, and then when you freeze that sample, it is frozen with the enhanced ROS, which is why some of the sperm gets damaged and you don't get as good a live birth rate when you use frozen PISA and frozen TISA sperm as compared to fresh PISA or fresh TISA sperm. So this is a very important new modification that we need to keep in mind when we often wonder as to why the second cycle with a frozen PISA or TISA did not give you the desired outcome that you wanted. A very important slide, and this was given to me by my very good friend, who is of course an international authority on male infertility, and that is Dr. Rupin Shah. And he said that especially for these three categories, he's been teaching us this for the last 2 decades now, in cryptozoospermia, virtual azoospermia, and necrozoospermia, make it a point to always, even if the initial sample shows that there is no sperm, always centrifuge the sample and examine the deposit. If you don't find sperm, take a second ejaculate, and there is a very high probability of finding a live sperm in the second ejaculate. He even goes to the extent of saying that there have been patients who have had sperm in the third ejaculate. Of course, provided the man is capable of giving you 3 samples in one morning, and often that would reveal live sperm. Also, in patients of necrozoospermia, we know that if all the sperm look dead, many a times you can find a live sperm, and if you can't, then testicular sperm aspiration would always be better in these patients to give you better quality and even motile sperm. In teratozoospermia, even if your laboratory reports show 100% abnormal, 99% abnormal, if the embryologist is skilled enough, he will always be able to find 5 to 10 normal morphology sperms even in these bad samples. So it's very important that he has to identify sperms with a normal head. Of course, pinheads we know have a 0% chance of pregnancy. Even round heads give very few pregnancies. So it's very important. You could ignore a bit of midpiece or tail defects, but you have to be very careful in selecting sperms with a normal head morphology. And even in the worst cases of teratozoospermia, usually you will be able to find enough normal morphology sperms to do an ICSI for most of these patients. So here we have a study now. Okay, we got all these bad quality sperms in these very bad patients of male infertility. What are the outcomes as far as the ICSI is concerned? Whether you get good fertilization rates, you get good embryos, you get good pregnancy rates. So here the best way to compare that is always to compare with donor sperm. And so here they had a study where half the oocytes were fertilized with the poor quality sperm of the husband, and half the oocytes of the same patient, of course with the consent of the patient, were fertilized with proven fertility donor sperm as a control. And of course, as expected, the husband sperm category did produce a lower fertilization rate. As you can see, 65 versus 83, but note it is still 65%. So it is not very bad. It's marginally lower than donor sperm. Even in cryptozoospermia, 70 versus 75, necrozoospermia, 65 versus 85. The zygotes derived in non-obstructive azoospermia, of course, had a lower cleavage rate, but the rate of resultant good quality embryos were not different. So this is very important point here. And the final pregnancy rates were pretty good in azoospermia at 36%, cryptozoospermia 40 versus 66 with donor, and even in necrozoospermia 20 versus 33% with donor. So you do get reasonably good fertilization rates, good top quality embryo formation, and decent pregnancy rates, even with the use of such poor quality sperm in patients with this severe male factor infertility. So what did this study tell us? Again, they stressed the same point that in non-obstructive azoospermia, please carefully examine the centrifuge sperm from 2 ejaculates, and which might be motile and have good morphology and would be suitable for ICSI. Even in cases of necrozoospermia, which is normally considered one of the worst conditions because of the presence of a huge number of dead sperm, you could isolate sperm in these cases with a careful search and a good centrifugation. And this is significant because you can avoid unnecessary TISA procedures if you have a good backup in the laboratory with an embryologist who is ready to go through these additional steps and make sure that they have done a thorough search to find good sperm for you. And that brings us to one category of male infertility, which somehow nobody talks of. And very often we hear that in conventional IVF, you get failed fertilization. So you have a patient with a normal semen report, normal looking oocyte, you do a conventional IVF, next morning you find none of the eggs had fertilized. Yes, you diagnose for the patient that, okay, failed fertilization was the cause of your infertility. And this is a huge problem, that this category is a very difficult category to diagnose before you actually do the IVF cycle. But do you have some option for them? And you must have heard that most of us then do something called a rescue ICSI. So I do a conventional IVF. I find that the same evening, if I've done an early denuding, or the next morning that there is no fertilization of the oocyte, we then go on to do a rescue ICSI. And this was a wonderful study here of 5,500 patients. 500 couples, they did short insemination. And if they had more than 30% fertilization rate, they were called the short-term IVF group. 100 patients odd detected total fertilization failure when the oocytes were examined 3 to 5 hours after insemination. And these were the ones where rescue ICSI was done. And you, of course, had 4,900 couples who underwent conventional IVF with overnight incubation. And that was the traditional IVF group. And to our surprise, you can see here, the clinical pregnancy rate in all three categories is the same. So traditional IVF, short-term IVF with early denuding, and rescue ICSI in the failed fertilization all give you acceptable and equal pregnancy outcomes. The trick, what I have been practicing for the last almost 5 to 7 years now, ever since we had a lot of freeze-all and vitrification in the clinic protocols, and we find that with rescue ICSI, try to avoid a fresh embryo transfer. Sometimes you might miss the window of implantation even if it's a day late, because as zygote, embryo, everything will develop one day late because you fertilize the oocyte one day late. So best is to freeze the embryos because the embryo quality is as good as a fresh ICSI, but sometimes implantation rates are lower. So it is important that when you do a rescue ICSI, the trick is to do a freeze all and don't do a fresh embryo transfer when you do rescue ICSI. So of course, this paper did fresh transfers and still showed the same pregnancy rate, but it's again your own experience. I feel frozen does much better in this category of patients. And that brings us to a very important area of male infertility, and that is sperm DNA fragmentation. We keep talking of DFI. A lot of DFI reports are advised to the patient, but what is the real role of this DFI? So we know that in unexplained male infertility or even cases of unexplained infertility in general, there is a higher incidence of DNA fragmentation in the male partner. Also, we know that this high DNA fragmentation might affect IVF and ICSI results. And we also know that more than 30% of men undergoing ICSI for moderate to severe male factor infertility show high percentage of sperm DNA fragmentation. Because of this DNA damage, you will have reduced rates of fertilization at conventional IVF. You will have impaired development of the embryo. You will have increased early miscarriages. This is very important that DFI, high sperm DNA fragmentation, is a cause of early pregnancy loss as well. So it's very important to remember this. The first paper came, of course, in 2000 when Larson showed with the SC assay, that is the sperm chromatin structure assay, that if more than 27% of sperms show high DNA fragmentation, you will not get a pregnancy even if your semen analysis parameters are normal. So you have a patient with a normal count, normal motility, normal morphology, but if you have more than 27% of DNA fragmentation, you are unlikely to get a pregnancy naturally or with IUI or with conventional IVF. The problem is we have too many tests available today for assessment of sperm DNA damage. There is no real standardization between the various assays. For example, the same man may show a higher DNA fragmentation with one test and show a lower fragmentation with the second test. Even within the same man, the same test, if done say 1 month apart, may show totally different or conflicting results. So as of now, this is the problem, that there is no definite cutoff and there is a lot of inter-assay, intra-assay variation with all the available tests as of now. And that is why it is not yet recommended as a routine first-line test for every male infertility who walks into the clinic. But it could be useful for these three categories of patients: those with unexplained infertility, those with recurrent IVF ICSI failures for some unknown reason, and patients of recurrent miscarriages. So these are three categories where estimation twice of the DNA fragmentation might be beneficial for these particular male factor patients. So here you can see how this was the huge paper in 2015 comparing live birth rates with IVF and ICSI and the connection or the correlation with sperm DNA fragmentation. And as expected, of course, patients with lower DNA fragmentation had higher live birth rates with IVF as well as with ICSI. But they went one step further, and when they corrected for female related infertility, they found that there was a shift in the ICSI group. So when you correct for female factor infertility, they actually found that ICSI is better and gives you better live birth rates in men with high sperm DNA fragmentation. So this is the important take home point here, that whenever you see a man with a higher DNA fragmentation, even if the count, motility, everything is normal, ICSI would be better than conventional IVF for this group of patients. You might also have heard a lot of talk recently that in patients with high DNA fragmentation, should you use ejaculated sperm at all? Or is it better to do testicular sperm aspiration? Because we know that a lot of the DNA fragmentation occurs during the sperm journey from the testicle to the outside. So if you remove or aspirate sperm from the source or from the testicle, would you get better clinical outcomes than using ejaculated sperm in this particular category of patients with high sperm DNA fragmentation? So this was one of the initial studies by Esteves in 2015, 172 patients undergoing ICSI. idiopathic oligozoospermia, persistently high sperm DNA fragmentation of more than 30%. And he clearly showed that when you use testicular sperm, you have a 80% reduction in the percentage of sperm having DNA fragmentation. So you can see here that testicular sperm considered to be much better than ejaculated sperm for patients with a high incidence or percentage of SDF. Again, this study, which compared ejaculated versus testicular sperm, no difference in clinical pregnancy. You can see between both the arms, ejaculated versus testicular, but significantly lower miscarriage rate with testicular sperm. So this in turn gave a much higher live birth rate when you use testicular sperm as compared to ejaculated sperm for this category of patients. I repeat, this is not being recommended for all patients of male infertility. This is only for patients who have high sperm DNA fragmentation. So we now have a lot of evidence, and there's one more paper here, meta-analysis, again favoring testicular sperm with ICSI for patients with high sperm DNA fragmentation. And yet once again in 2018, again showing much higher live birth rate with testicular sperm, although fertilization rate was similar, number of top quality embryos was similar, but clinical pregnancy rate shot up from 14 to almost 40% when testicular sperm was used for patients with a high SDF. Then there were the counter argument papers that yes, testicular sperm might have lower DNA damage, but it has significantly higher aneuploidy rates with chromosomes 13, 18, 21, X and Y. And here you see this paper which showed that testicular sperm DNA damage was less, 40.6 went down to 15%, but aneuploidy rates from 5.77 went up to 12.41%. So this was the slight controversy here, that even if you get sperm with lower DNA fragmentation, you might be having sperm with higher aneuploidy. But to counter that, again, we have this more recent study that when they changed the method by which aneuploidy screening was being done for these patients, they found the reverse, and that is a higher incidence of aneuploidy with ejaculated sperm as compared to testicular sperm. So again, proving the point that testicular sperm is better both from the point of view of DNA fragmentation as well as aneuploidy. And of course, we need more RCTs to confirm this finding, but very interesting that by changing the method of aneuploidy screening, they actually showed a reversal of role of testicular and ejaculated sperm. So what do we know as of now for sperm DNA fragmentation? That of course you have to treat the underlying conditions when you have a high sperm DNA fragmentation like varicocele, antioxidants and so on. You also have to consider that you might get higher aneuploidy rates even if you get sperm with lower DNA fragmentation with testicular sperm. But I showed you that recent paper, which is some kind of a good news for us. We also need more evidence to know, okay, who exactly can really benefit from this strategy. But the current evidence and a lot of papers which are available currently suggest that testicular sperm is better than ejaculated sperm and more promising in these patients to deliver a better live birth rate. We also hear a lot of talk of IMSI, that is intracytoplasmic morphologically selected sperm. Of course, there are publications both for and against. Again, it's your personal experience. But you can see here that the Cochrane analysis concluded that the results from the available RCTs do not support the routine clinical use of IMSI, and there is no evidence of effect on live birth or miscarriage, and that the evidence that IMSI improves clinical pregnancy rates is actually of very low quality. So right now it's still a status quo. We don't know whether it really benefits the patients. And the same is with all these newer things which you keep hearing like physiological ICSI or PICSI. And again, this systematic review with all these meta-analysis shows that there is no statistically significant difference between PICSI and ICSI as far as live birth rates are concerned. Of course, we cannot have a talk on male infertility and not talk about azoospermia, because almost 15% of male infertility will be the azoospermic men. And here we of course have the two common categories. One is obstructive azoospermia, the other is non-obstructive azoospermia. Obstructive, of course, ejaculatory duct obstruction. One of the commonest categories we get in practice is congenital bilateral absence of vase. We actually wait for these patients because they have the best sperm quality and the easiest to retrieve with just a 26 gauge one shot. Usually you get very good sperm. FSH of course will be normal, testosterone will be normal, testicular volume will be normal, and you will have a full epididymis on clinical examination. And of course, on the other hand, you have your non-obstructive azoospermia, which is the more difficult category, where usually quite often FSH might be increased, testosterone may not be normal, testicular volume may be reduced, the epididymis may be flat, and so on. Of course, that's more of an embryological part, but from the gynec point of view, you have several techniques here for aspiration or retrieval of sperm. So you first, the commonest of course is PISA, that is percutaneous epididymal sperm aspiration, done with a simple 26 gauge needle for cases of obstructive azoospermia. You then have TISA, that is testicular sperm aspiration, which is indicated if PISA fails in obstructive azoospermia, or congenital bilateral absence of vas where the epididymis also has agenesis, so there is no full epididymis from which you can aspirate sperm. If you have favorable testicular histopathology in non-obstructive azoospermia cases, and if any previous attempt of TISA in that patient has successfully yielded sperm, all these would be indications for doing TISA. And then of course you have multiple biopsies, that is TISA, if all the above have failed. And finally, and the most recent and the most fascinating, is micro TISA, that is microsurgical testicular sperm extraction for very bad cases of non-obstructive azoospermia, where PISA, TISA and all multiple attempts do not give you any good viable sperm. So PISA, of course, very simple technique. You can see here, just under local anesthesia. This is Rupin doing it at our clinic, and he just injects the local anesthetic in the region of the epididymis and waits for about 4 to 5 minutes, rubbing it in for it to work and have effect. And then all he has to do is just, that's how the local anesthetic is being spread out. Yeah, that's the 26 gauge needle. You can see with a tuberculin syringe being injected in the epididymis, aspirated with some little culture medium in the syringe. And that's how easy it is. And then the syringe is sent to the embryology lab where they will screen. And usually in a case of CBAVD or a classic obstructive azoospermia, the first or the second aspiration would give you lots and lots of good morphology motile sperm. So this is of course one of the heartening areas where the results are really good with epididymal sperm aspiration. Of course, the misconception is that all obstructive azoospermia needs PISA with ICSI, and this is a very important, again, area which needs to be understood, that VEA and other options should always be explored in consultation with your andrologist. Please remember that a patient always prefers natural conception versus IVF. So it is important to discuss all options with the patient before you make a decision. And just to compare the two, for example, a VEA is a daycare surgery, 60% chance of getting a sperm count in 6 to 12 months, 30 to 40% chance of a natural pregnancy, less expensive, second and third child come on their own, don't need any treatment, and the patient can freeze sperm for future ICSI. On the other hand, ICSI, quicker time to pregnancy, you don't have to wait the 6 to 12 months. If it's successful, it's within a month or two. No surgery involved for the male partner. Of course, the normal female partner has to take a lot of hormone injections. 50% chance of a live birth, quite expensive as compared to VA, and every attempt is charged separately. So these are the, of course, pros and cons of doing VA versus a PISA and ICSI. But when is ICSI preferred and where you don't have to think too much that no, this patient does need ICSI straight away? If you have an elderly patient, say the female partner is 37, 38, with a low AMH, or even a young patient with a low AMH who doesn't have time on hand from the female partner point of view, or the couple is an extreme rush and cannot wait the 1 year for a pregnancy, or patients who are not good candidates for surgery, such as those with extensive epididymal damage with filariasis, tuberculosis, hydrocele surgeries, and so on. So it's again an important decision to be taken that not every patient has to rush into ICSI, and there are other options which are equally successful. Then of course you have TISA, where we just use a butterfly set and to take about 3 to 6 biopsies from each testicle. And this is usually done if PISA fails, if PISA doesn't give you sperm in an obstructive azoospermia, or of course all patients of non-obstructive azoospermia where a TISA ICSI would be the preferred treatment of choice. So of course this is the conventional TISA which we used to do, TISA, which was an open biopsy, which we no longer do. We do multiple needle biopsies from both the testicles, and you have the more modern micro TISA. Now, what are the pros and cons of this? With conventional biopsy, the advantages were, of course, a short surgical time, Disadvantages were decreased rate of sperm retrieval because you just take a random biopsy from one area of the testicle. And in these difficult cases of non-obstructive azoospermia, there may be just one area in one testicle which might be producing a few sperm. And that is why it's important to take 3 to 6 biopsies from different areas of each testicle. More chance of complications such as hematoma because you might injure inadvertently testicular vessels, and sperm retrieval rate is usually around 45%. On the other hand, with micro-TSA, you have a sperm retrieval of almost 63%, less damage to the testes because under the microscope, you can totally avoid damage to any vascular structures. Testosterone levels return to 95% of the baseline as against 85% with conventional biopsy. Disadvantage is, of course, long learning curve, availability of an operative microscope of that category, the need for general anesthesia, and of course, it takes an hour or two to do the procedure, and therefore the cost factor also comes into play. A very important slide here, and a lot of us see one report of a histopathology of a previous testicular biopsy which says no spermatogenesis seen, and we assume that this patient needs a donor sperm, and we straight away tell the patient you have no other option except to take sperm donation. Please remember this slide, very, very important, that 20 to 25% of men with a histopathology diagnosis of Sertoli cell only syndrome, which we so commonly see, 35% of men who have a report of a testicular biopsy showing maturation arrest, and more than 90% of men with severe hypospermatogenesis as the diagnosis would have normal sperm retrieved on TISA. So this is very important. Don't jump to the conclusion that if the histopath report of a random testicular biopsy in the past says no spermatogenesis seen, that this patient will not have a sperm. So it's always worth trying, and you must consult the embryologist to make sure that this patient may or may not, is it likely that this person will be in one of these categories of patients as shown here. So just because a single biopsy report is unfavorable, do not write off all hope and directly advise donor sperm to these patients. Comparing micro-TISA to conventional TISA, of course, conventional TISA cannot, as I told you earlier, discriminate areas of the testes with sperm production because it is more of a random sampling. Micro-TISA, you can see the more opaque seminiferous tubules because these are the ones more likely to contain active sperm. And of course, you have a minimization of post-operative complications because you can accurately identify blood vessels when you use a microscope, and you can also identify which tubule is the best by seeing its opacity, and therefore you have a much better targeted approach to sperm retrieval. So you can actually study and see the seminiferous tubules which are most likely to contain sperm. And you can see this study, a very initial study from 2013 when micro-TISA first came in. Sperm retrieval rate, you can see from various categories of male infertility, patients of chemotherapy, sperm retrieval rate of almost 48%, pregnancy rate 40%, Klinefelter 65%, cryptorchidism where we usually write it off 64% chance of sperm recovery, AZFC deletions 72%, overall all categories put together more than a 50% chance of finding sperm with micro-TISA, and excellent pregnancy rates in all these very difficult cases of male infertility. So of course, we know that micro-TISA is a very effective method for treatment of non-obstructive azoospermia and will help a lot of these patients when combined with ICSI to obtain their own genetic offspring. So again, this paper showed when you have hypospermatogenesis on histopathology report, 100% sperm recovery with micro-TSA in patients of cryptorchidism, 60.9%, Sertoli cell only syndrome, 11.8%, spermatogenic arrest, 0% as per this particular paper from 2018. But the downside, and the practical pointers, very important that you need a very high level of commitment by the clinician and embryologist and the patient himself, and each person understands their responsibility and the fact that you may not get sperm sometimes and it might fail after all the effort that has been put in. Most clinics in India or even abroad or elsewhere do not give the amount of time that is required in the laboratory for these samples which are retrieved at micro-TISA. You need a search time of 3 to 4 hours, often not by one, but by multiple embryologists. So the more eyes which you use, the higher the chance that you find a sperm. Often requires incubation, centrifugation, researching after 2 to 3 hours. Also, miscarriage rates are higher with the use of this micro-TISA sperm in a lot of categories of patients, expected because the sperm is not as good as a normal sperm, and lower live birth rate than other categories. But The good news is that all the babies are normal, so you don't have to worry on that front. So the male partner has to be counseled that the chance of finding sperm is say just about 20-30%. The chance of pregnancy will be about 20-30%, not the usual 50-60% which we get for other patients. But if you get a pregnancy, the baby is likely to be normal and you don't have to worry, because that's a usual concern. A lot of these male partners have that with all this intervention, will the baby be normal or not normal? And of course, we know that high FSH with small testes might have a lower probability of finding sperm. Normal testes with normal FSH would have a higher probability. In the worst of cases, multiple biopsies, or you might just have one or two focal areas, which micro-TISA helps you to find that one opaque seminiferous tubule, which might contain sperm in that patient. And pregnancies have been reported even in patients where they have just found 3 to 5 spermatozoa. So remember, don't write off the patient. Spend enough time in the laboratory and have a backup team which really spends time on the patient and helps you to find the sperm in the lab. And this is a paper from 2014 which shows the importance of search time. And it is very important that when spermatogenesis is severely compromised, you need an extreme search by the embryologist to find sperm. And you can see here, the green bars are ejaculated sperm, orange are testicular sperm, and this is the time which was required, the search time to actually find sperm and inject. And you can see, even if you find sperm beyond 3 hours of searching, you still get a 50% pregnancy rate with ejaculated sperm, and you still get a 24% clinical pregnancy rate with testicular sperm. So very important slide here, that the more time you spend, you will still find sperm, and it doesn't mean that the more time you spend, the less the chances of pregnancy in that particular patient. So the key points of this particular study, which I want to highlight, is that even, just to repeat what I told you earlier, that even men with non-obstructive azoospermia, please ask them to produce and ejaculate on the day of the scheduled TISA or micro-TISA. And very often you will find sperm in these patients, by which you totally have to avoid the procedure which was scheduled, and an unnecessary TISA or micro-TISA will be avoided. So very important, because some patients, even in this particular study, in 17 patients, which is 10% of the total men, they were able to find sperm in the ejaculate on that morning, although it was a documented case of non-obstructive azoospermia, and therefore TISA was avoided, and they got a good clinical pregnancy rate of 44%. Also, in this category, expect that almost 15 to 20% of patients will have abnormal karyotypes, large majority being Klinefelter, followed by Y microdeletions and so on. So very important to be aware of associated genetic anomalies. And as I told you earlier, the main important thing is that the search time could be as high as 3 to 4 hours for ejaculated sperm, and even as high as 6.5 hours for surgically retrieved sperms. Also, the searches in this particular study involved 3 ICSI operators and sometimes up to 8 additional embryologists. So you can imagine almost 10 people are working on one testicular sample, and then they had such good sperm recovery and such good pregnancy rates. So this is very important. Only if you have this kind of an infrastructure is micro-TISA likely to give you good results, because otherwise we hear a lot of centers saying, oh, micro-TISA doesn't work, we didn't find sperm, we did 10 patients, nobody got pregnant. So please remember that these are the key points when you are having micro-TISA for these patients. And something which I really feel strongly about before we end, of course, and that is the practice of ICSI for all patients. Now, of course, male infertility, there is no argument you need to do ICSI, but we find 95% of Indian clinics do ICSI for each and every patient. Even if you look at Western statistics in UK, for example, if I talk to colleagues there, 60% is ICSI, 40% is still conventional IVF. In US, it's about 70-30 ratio. But in India, whoever I talk to does ICSI for all. So they just do the egg retrieval. They have a visiting embryologist who does ICSI for all the patients. And then they say our live birth rates are not very good. Not one, but look at the number of studies that you have against this. ICSI does not offer any advantage over IVF. You can see here 2001 and SART data 2016. Again, TANUS, no clear benefit in using ICSI over conventional IVF. Low incidence of failed fertilization with IVF. ICSI has fewer live births. IVF versus ICSI, blastulation rates are higher, clinical pregnancy rates are higher, live birth rates are higher. IVF gives higher pregnancy rates than ICSI in non-male factor infertility by Hansiver in 2016. So you have so much evidence that IVF is superior to ICSI when you don't have a clear-cut male factor. And this recent paper comparing the two again, you can see IVF versus ICSI, number of zygotes, blastulation rates, everything was better with conventional IVF. And fertilization rates were the same. Failed fertilization also the same at 9% in both IVF and ICSI. And of course, live birth rates marginally better. So what is the need to do ICSI for all these patients? Some people say, oh, if you get only 1 or 2 eggs, ICSI is better. I don't know how this mental perception comes about. Here, clearly, you can see this study which shows that ICSI does not have any advantage over IVF, even if the oocyte yield is low, even when only one oocyte is retrieved. So definitely, you can see here IVF with 3 oocytes, 60%. ICSI, if you do for 3 oocytes, 52%. 4 oocytes, 64 versus 56. So even with lower number of oocytes, ICSI does not give you any benefit over IVF. We know that there are risks with ICSI because you have an exposure to much more chemical influences like hyaluronidase, PVP. The gametes are outside the incubator for a longer period of time. So you have temperature and pH fluctuations. Cost involved is higher. You require a skilled embryologist who is skilled and perfect with ICSI techniques and so on. So we really don't know that why are we performing so many ICSI cycles as compared to IVF. And this is a very good point made by Hans Iver that ICSI on non-indicated patients has prevented 25,000 couples from achieving pregnancy, which he wrote as editor-in-chief in 2016. So please try and do more and more conventional IVF. It is really good and gives you better pregnancy rates as compared to ICSI. Of course, finally to end, there is a lot of perception that ICSI causes abnormal babies, more miscarriages, lower pregnancies. This was, of course, the original famous study from Belgium, where you had the largest number of patients, 4,268, pregnancy rates around 56, clinical pregnancy 45, ongoing pregnancy around 40. Another paper, is there an increase in congenital anomalies? Again, ICSI versus IVF. Total malformation rate was in fact less than seen with IVF. But of course, in this paper, they saw that ICSI tended to be a younger age group because it was just male factor and they resorted for treatment early. IVF very often is the above 35 age group. So there was a slight increase here. But compared to natural conceptions, there was no increase in any malformation rate with ICSI. What about testicular sperm versus normal sperm? Of course, we know that with severe cases of non-obstructive azoospermia, live birth rates will be lower if you compare to donor sperm or obstructive azoospermia, as I showed you earlier. Epididymal is the best. But the main point is that the newborn parameters of infants conceived were not significantly different. So this is the very important counseling point to be told to the patient, especially non-obstructive azoospermias, that yes, the chance of finding sperm may be less, pregnancy rate may be lower, but your baby will be normal. So this is very, very important and very important point to be told at counseling to all these patients. And of course, we know that with testicular failure, you will not expect pregnancy rates as with the donor sperm, but they are reasonably good, and TISA and micro TISA are definitely the male partner and the couple understand the prognosis, the chances, and the efforts which will be required by all concerned. Another very interesting paper here of Klinefelter syndrome. 65 patients with non-mosaic Klinefelters who were treated with TISA and ICSI. Sperm recovery was seen in 40% of the patients. 16 clinical pregnancies, 14 had a successful delivery, 17 newborns, and this was very important to reassure men with Klinefelters that there is no increased risk of transmitting their genetic problem to the offspring with TISA and ICSI. So again, very important counseling point. What about safety? Of course, there were a lot of critics who said that ICSI completely bypasses natural sperm selection. So we are not sure what effect it will have on the growth, the cognitive development, the postnatal well-being of the offspring, and their future reproduction. There was major concern that the male offspring might be born with the same genetic problem and might also suffer from infertility in the future. But as of now, most of the literature which has followed up these babies from neonates to adolescents have shown absolutely normal physical and psychological development. You have a lot of studies to that effect. What about male offspring being infertile? A second recent study of these young ICSI men showed that it was comparable to their normal peers. Second study demonstrated slightly lower semen parameters in the ICSI cohort, although all metrics were still considered above threshold according to WHO criteria. And the fact that these ICSI offspring have semen parameters within normal range, and therefore this is very reassuring that it may not be true that they are going to suffer from the same infertility that their father suffered from. Even for the female offspring, we have a recent study, 2017, very encouraging results in relation to their fertility. comparable hormonal profile to naturally conceived girls. Future management of non-obstructive azoospermia, where is the future? We know Sertoli cell only could be treated with transplantation of stem cells to repopulate the germline epithelium. Embryonic stem cells, gene therapy, challenges, of course, we all know about all these things. And to end, of course, the very important recent review, which I thought I must share with you, because there is always concern about whether we should do ICSI on immature oocytes. What about how to avoid oocyte degeneration? Many times, in a new lab, you inject 10 oocytes and the next morning you find 5 are degenerated. What should be the timing after egg retrieval? When should you inject the eggs? Where should be the polar body, so on and so forth, use of round-headed sperm, immotile sperm, what about high DNA fragmentation, which we discussed. And according to these studies, they conclude that injection of metaphase 1 oocytes, which a lot of clinics continue to do, should be discouraged because you have very high aneuploidy rates and poor outcomes. Laser-assisted ICSI, if it comes in the next 2 or 3 years, will replace the manual ICSI, and that would be an efficient method to reduce the oocyte degeneration rate. Optimal ICSI timing and best polar body position have not yet been clarified. Injected zona-free oocytes, if handled carefully, can develop to the blastocyst stage and implant, and efficient options can be offered to patients who have suffered fertilization failure in previous conventional ICSI cycles. So of course, to conclude then, the main challenges for the future still remains that we still don't have any method to select the best sperm or to select a viable sperm when only immotile sperm are available for ICSI. We don't know yet how to filter out sperm with fragmented DNA from an ejaculate. Although we do ICSI, ICSI gives you a better outcome, but we still cannot eliminate this problem completely. And most of the studies do not report essential outcomes such as miscarriages, anomaly rates, and so on. So although I showed a lot of data establishing safety of the procedure, it's important that whenever anyone presents or publishes something to do with ICSI, we must have the final clinical outcomes as well. So with that, once again, thank you, ladies and gentlemen, for being really patient through this entire long marathon session on ICSI and male infertility. And thank you, Shield, once again. And I'll go back to Kiran now in case we have any questions.
Sir, thank you so much for a wonderful and lucid talk. You covered all the aspects. I'm sure the audience enjoyed the same. Sir, there are quite a lot of questions. I'll just read them to you. So the first question is, what is the role of IMSI? Do we need such magnification to choose a morphologically normal sperm?
No, so I showed a slide on that as of now, we don't have any concrete evidence that IMSI is of much benefit. So in good hands with a good eye, normal routine ICSI is equally good for selecting good normal morphology sperm. So there is no data to show that IMSI is superior to conventional ICSI for any particular category of patients. But there are groups who have a lot of experience with IMSI, especially in some very difficult cases of repeated IVF ICSI failures or very bad teratozoospermia where you need a lot of magnification to select very good sperm. If you just feel that most of the sperms are of not ideal morphology, then these are these rare, maybe 2%, 3% of patients who might benefit with IMSI. So that would be my answer for the role of IMSI.
Thank you, sir. Sir, you spoke about ICSI at length. So there's a question from Dr. Millen. Do you advise ICSI for all, especially in older men?
No, that's what I showed. Whether it's older women, whether it's less oocytes, whether it's older men, these are not indications for ICSI. So please, for ICSI, it has to be male factor infertility or some cases of unexplained infertility where you suspect that fertilization failure may be the reason. So these are the only two categories who are straight away indicated for ICSI. But anything else like tubal factor, elderly age group, less oocytes, poor responders, all these who are till now being categorized as ICSI cases don't really need to do ICSI. So ICSI for all is totally out, not required.
Thank you, sir. Sir, is there any specific advice which has to be given to patients before going in for sperm extraction?
No, the counseling part is very important. So for obstructive azoospermia, like suppose you have a case of CBAVD, congenital bilateral absence of vase, we always encourage them. We tell them, oh, 99% you will get sperm and 60% chance that you will have a pregnancy in the first shot. Whereas say you have a very bad case of testicular failure with low testicular volume, high FSH, small testes, then obviously you would tell them that there is just a 10% chance of finding sperm and maybe just a 20 to 30% chance of a pregnancy, if at all we even find a sperm and get fertilization. So counseling is very important. You have to make sure that the couple understands the prognosis because these are difficult cases. Statistics are good, data is good. A lot of publications are in favor of doing TISA and micro TISA, but at the end of the day, we have to see the affordability, whether the patient can do it again and again. IVF is never a one cycle treatment. So all this initial counseling is very important for the couple before you embark on sperm retrieval procedures. As far as the procedures are concerned, they are quite simple, safe, devoid of complications, in good hands. So there is not too much of operative counseling to be done for the procedures as such. But the prognosis and the chance of a pregnancy has to be explained at length.
Thank you, sir. Sir, what is VEA? Question from Dr. Rekha Gupta.
VEA, that's a vasoepididymal anastomosis, no? VEA
Yes.
surgery. Yeah. That is a recanalization surgery for blocked vas deferens.
Okay, sir. So there's a question from Dr. Sparsha. How can one do early rescue, that is 6 to 8 hours? Because according to her, generally the first check is done after 18 to 22 hours.
No, that is conventional IVF where you check at 18 to 22 hours. So I showed you those 4,000 patients were in conventional IVF. 600 did the short denuding. Even at our own clinic, suppose we inseminate at 9 in the morning, we denude the oocytes at 2 o'clock or 3 o'clock in the afternoon. So within 5 to 6 hours is when you can denude and make out if there is fertilization failure. So you don't have to wait for the next day. Early denuding gives you the same results, and you can examine the 2PN at a very early stage. And if it is not there, you can immediately do a rescue ICSI the same day. So although everybody has been doing 18 to 22 hours, but a lot of clinics are doing the early denuding since the past 8 to 10 years now. I think it's been in practice for us. Like even say, for example, just as a practical shortcut, suppose Sunday my embryologist doesn't want to come, and Saturday morning we've done an egg retrieval with IVF. Saturday afternoon before she leaves, she denudes and transfers them to fresh culture medium, and then directly checks the embryos on a Monday. So you don't need to do visit the clinic on Sunday and do any additional work on that day. So this gives you the absolutely the same results. There is no difference, and you have an early diagnosis of total fertilization failure. So rescue ICSI, the earlier it is done, the better is the outcome. So that is what that paper showed there. You denude within 3 to 6 hours of the insemination.
Yes, sir. So the next question again is related to the same thing. It is from Dr. Pushi. What she wants to know is if we do IVF and fertilization of the egg doesn't occur, how much time do we have to do rescue ICSI, and how are the results?
No, so ideally the same evening is the best, and even the next day is fine. Till now we were always doing the next day. And as I told you, personally didn't have very good results with fresh transfer, although embryos used to be as good as a fresh ICSI. So we started doing freeze-all and frozen transfers, and we are back to the 50% pregnancy rate with frozen transfer in rescue ICSI cases. So very important thing is that the embryo quality is the same as you would have done a fresh ICSI. So that is a good point. A lot of people feel that rescue ICSI, the eggs will be damaged, embryos will not be good, the implantation potential will be affected, and so on. But that doesn't happen in practice as long as you do frozen transfer. So don't do a fresh transfer, just freeze the embryos and transfer them in the next month.
Thank you, sir. Sir, what are your thoughts on the use of microfluidics?
That's a developing field. Let's see. I think the next 3 or 4 years will be exciting. Even laser ICSI will be very exciting to see, because that will remove, oocyte degeneration, especially a lot of new labs. Initially with the new embryologists, a lot of the oocytes do tend to get degenerated because of the manual, learning the practical points. So once you have a laser assisted ICSI, I think a lot of that will change as well.
Thank you, sir. Sir, what are your comments on the use of MAX, which is MACS, in cases of raised DFI?
What is MACS? I'm not sure.
I have not mentioned, sir. Okay, so I think we'll move on to the next question. Sir, you spoke about antioxidants at length. So Dr. Kavita wants to know what antioxidants you use personally, and how long do you use it before IVF?
Yeah, so I like to give a ARG9, and we also give a combination of ubiquinol 100 with resveratrol 40 milligrams. So that we give for a minimum period of 3 months before starting the IVF cycle. So that is usually what I personally prefer. But you have a lot of formulations in the market, and most of them give you equally good results as you give them as long as you give a good amount of coenzyme Q, maybe vitamin C, vitamin E, and I find resveratrol very helpful as well.
Thank you, sir. Sir, what are your thoughts on some of these, I would say, enzymatic antioxidants like superoxide dismutase and glutathione peroxidase? Do they have any role in idiopathic male infertility and all so, sir?
No, I don't have personal experience. So as of now, I showed you that large study which they did recently, and what I use personally.
Right, sir. So the next question is from Dr. Satya. Can you please comment on artificial oocyte activation, sir?
This is still a developing field research stage as of now. So we don't know. I have two patients where they have been doing repeated cycles of oocyte activation in Tokyo, and I have not seen a pregnancy as yet. But of course, there are reports of it being successful, especially very low AMH or the elderly age group. So it's an exciting area, but we still need more papers, more RCTs before we start doing it routinely.
Right, sir. Sir, what types of sperm preparation for ICSI and IVF do you recommend or follow?
So for IVF, with a normal sample with normal sperm count, motility, and morphology, we like to use the layering method. So it's very easy. You just take 4 test tubes, put 0.5 ml of culture medium in each, and then underlay the culture medium with liquefied semen. Incubate this for about 30 minutes. So it utilizes the intrinsic motility of the sperm. So rather than you using harsh centrifugation, which could release ROS, the sperms use their own motility and swim up into the supernatant. After half an hour, we pull all the supernatants, then centrifuge, because now you've removed all the dead sperms, RBC, WBCs, and so on. So there is very minimum release of ROS, and then use that pellet for the final insemination in IVF. For ICSI, we prefer, and you have to use the gradient method because they will usually be cases with very low sperm counts, very poor motility. So the intrinsic motility may not be enough to give you a good retrieval with the layering method. So you have to use a gradient method, wherein all the motile sperms in the original semen sample will swim down, will be pushed down to the pellet with centrifugation through the 2 gradients, usually 40 and 80 or 45 and 90, and give you a good recovery of sperm, even in the worst cases of oligoasthenoteratozoospermia. So these two are different methods, and that's a very good question because that point needed to be covered.
So what are the different criteria for conventional IVF?
For conventional IVF, any female factory infertility, tubal factory infertility, patient with previous ectopic pregnancies, any patient with a previous early pregnancy loss. Why these factors? Because then you have proven fertility. You know that her eggs have been fertilized by their husband's sperm. So if you have proven fertility, you know that she cannot have failed fertilization in IVF. So any secondary infertility will be a candidate straight away for primary IVF. Even patients of unexplained infertility where I see absolutely normal sperm factor and I feel that it's a borderline AMH or a egg oocyte problem, we prefer to do IVF because the incidence of failed fertilization as per the international literature and our own experience is very, very low. So it's a bit overhyped. And even if that occasional failed fertilization occurs, you can always do rescue ICSI and a frozen transfer and get the same pregnancy rate back. So almost 40 to 45% of patients in our clinic undergo conventional IVF, and just the remaining 55% or so will undergo ICSI. So it's almost a 50-50 ratio IVF and ICSI at our clinic.
Right, sir. Sir, there was an earlier question on MAX. So Dr. Naresh Prabhu explains that it is magnetic assisted cell sorting for routine sperm selection.
Oh yeah, actually, okay. So that was so now that we've not used this, so I don't have much practical experience with it. I have probably read the same as what he's read. We still are looking, because I was in talks with the Israeli company where we are trying to devise some technique wherein just by volumetric study of the sperm, you can find out if that sperm has normal DNA or not. So that is the main important concept, where you will have 100% separation of normal DNA sperm from fragmented sperm. Now this is still in the research stage and still not it has come out. I think magnetic assisted sorting is also pretty reliable, but I'm not sure of the statistics that do you get 100% separation of normal and fragmented sperm, or is it some mixing still occurs. So we need a little more research there, but it's a good question. And since so many people are asking, I think I need to read up on that.
Sir, there are a few papers which I came across recently which speak about the role of myoinositol in improving the sperm function. Any thoughts on that, sir?
Myoinositol, no. Not.
Yes, sir. One question from Dr. Kushi. What is the sperm concentration for IVF per oocyte?
Usually it's 100,000. So 100,000 sperms per oocyte minimum you need, but up to 500,000 is also okay. There's no problem. Too much of sperm is to be avoided because otherwise you get polyspermic fertilization. So usually there is a counting chamber and just 1 to 200,000 sperm per oocyte usually suffices.
Right, sir. Sir, there are a lot of requests for a presentation. I think we are actually recording this session, sir. So with your permission, we can probably share the recording as well.
Yeah, sure. No problem. Great.
Yeah. Yes, sir. Thank you, sir. So lots of compliments from.
Yeah, I'm seeing them on the chat. Thank you. Thank you
Yes,
to
sir.
everybody. Thank you to the audience for always being so appreciative. So that keeps us going with these webinars.
So there's a comment from Dr. Natesh Prabhu. Myoinositol-based supplements can be given for patients with low FSH.
Again, I don't have personal experience with that because most of the time we just give the routine antioxidants, and anything which is a bit complicated, we refer to the andrologist because it's not in our domain to keep medicating the male partner. So normally I prefer to send the patient to Dr. Rupincha or one of our andrologists who will then give all these treatments. At the most, we use the ubiquinol with the resveratrol for 3 months if it's idiopathic or whatever, high DFI.
Hello, sir. So can I ask a question now?
Sure, no problem.
Yeah. Dr. Natesh Prabhu here.
Yeah, hi Natish.
I have attended your talk recently also. Excellent speaker, sir. I just want to give a compliment for you.
Thank you. Thank you.
So a few clarifications, because we had a geneticist from a National Institute of Research. Yeah, like they released a recent draft. ICMR has released a recent draft saying that if the patient is having any sperm count less than 15 million per ml, it is very wise to do YCMD. Why? Because when there is YCMD positive, or Y chromosome microdeletion positive, then we proceed with DFI, because anyway we know, like when there is YCMD, there will be high DFI,
Yeah.
and the role of antioxidants won't be there when there is YCMD. So we have to go a side ahead for ICSI and do a PGT and further do a transfer.
Yeah, that's a good approach. I showed you that part also. So that's not a problem. These are all gray areas. So, there'll never be a black and white. It's always going to be gray. Okay, whether to do ICSI, whether antioxidant. That's why antioxidant till now we all thought it was empirical, but now we are getting studies and trials where they're actually showing documented that there's improvement in all the parameters, reduction in sperm DNA fragmentation. So that's an interesting point you made there.
Sir, which DFI testing method you use? Like, do you use SCSA or SCD?
No, SCST, I think.
SCSA.
Yeah.
By flow cytometry. And you use Meoxis for ROS?
We're not doing it routinely as of now. We just give the antioxidants anyway.
Okay. So, and like any specific say on this, what is it, resveratrol? So which patient do you prefer resveratrol?
No, all of them. It's an anti-aging agent, and somehow we've had very good results both for low AMH in female infertility and for all kinds of male factor in male infertility. So it really works well.
Thank you, sir.
Yeah, thank you. Okay, Kiran. So I think we can wind up here.
Yeah, sir. So thank you so much on behalf of Shield Healthcare as well as the audience, sir, for giving a wonderful talk. And as usual, it was very in-depth, and thank you so much for patiently answering all the questions also. Thank you so much.
My pleasure. Thank you. Thank you, everybody. Thank you.